So thank you very much. So I'm going to give you the usual disclosures, but my main disclosure actually is how much I struggled even more so than usual with my usual high level of angst about this topic. And I realized I could make it a 2-minute talk so that you guys could get to break earlier. I could make it an hour and a half talk, and I figured that I should probably actually try to tailor this around the time limits given. And so when I put this talk together, I was really trying to think of the best way to frame it, especially with the topic at hand, which is how do we counsel patients who are going to undergo surgery? And as my wise friend Dr. Kappelman said, it should be pretty straightforward because we do this and often. But at the same time, I always wonder, am I doing it the right way? So there are two things that really guided this talk as I came put this together. And one was actually the very wise words of Dr. Joel Rosh a few years ago when he talked to us about how we should have discussions with patients and not using words like failure necessarily, especially when we say, quote, a patient failed a certain medication. Patients never fail medications. Medications fail them. And I think it really sort of emphasized how we need to talk to our families as we discuss surgery. And then the other piece was really something that really struck home personally when my father had to make some major decisions about surgery, and I thought about what was important to my family as we went through things. So being kind of a data-driven family, one of the things that was really important to us was to know the information. So the first piece that I'd like to do is really review the incidence and prevalence of surgery in our pediatric patients who have IBD. And then the next thing we wanted to know were what are the risks, what were the indications, relative and absolute, what were the different options. So we'll discuss that today when we have our discussions with our children who may need to undergo surgery, whether it's Crohn's and ulcerative colitis. The third piece we wanted to know is not just what led to the decision for a certain surgical modality, but what are things that could happen after the procedures. So I hope in the short time I have that I can at least address some areas of concerns, knowing that I'm not going to be able to hit on everything, but I'd like to highlight a few areas. And finally, looking at what the patients struggle with and what are their own fears about surgery as we really frame our discussions. So, we can have different ways. So as a medical student at Michigan, we heard steel heals, to cut is to cure. So we know that that's not the case. Are you someone who says you must avoid surgery at all costs because it could be actually seen as a failure of ourselves as physicians? Or use anything possible? And when we say anything possible, is it surgery? Is it medications? Is it nutrition? Is it a combination of all of those above? So we all know as pediatricians here that our children and young adults bear a disproportionate burden in regards to disease, medically, psychosocially, financially. And so there have been several elegant studies that have looked at children and young adults who live with IBD, and we know that with both Crohn's disease and ulcerative colitis that there's a much greater likelihood of children who have IBD to have more severe disease, need for hospitalization when compared to adult patients. And so, for Crohn's disease, certainly higher incidence of perianal disease. We'll talk about surgery risk. Ulcerative colitis, especially a higher incidence of pancolitis, and a good proportion of the children who we take care of with UC, and that a good percentage of our kids who have ulcerative colitis will have at least one bout of severe disease exacerbation in the lifetime of their disease, if not more. And so I think a lot of you may be familiar with this really seminal study. So it was the French study that was published along with Van Limburgen's study, where we know that children with pediatric onset Crohn's disease will often progress to more complicated phenotypes of the disease, whether it's stricturing or penetrating. And while children with Crohn's disease may have a longer interval of time, as shown in Van Limburgen's studies, almost 14 years to getting to their first need for surgery versus about 7.8 years for adults, there's still a significant percentage that we need to think of when we think about the need for surgery. And I say this because it's something that we, as pediatric gastroenterologists, when we diagnose our kids, when we treat them, we need to have that at the back of our minds. And so I think a lot of you are familiar with, and I suspect we're involved in these two very comprehensive studies led by Drs. Neera Gupta for the study in 2006 and then Dr. Mark Schaefer in 2010. And really the bottom line, very similar findings when they looked at 5 and 10 years, that as Dr. Gupta and colleagues showed, that almost 30% of patients with Crohn's disease would at least require some sort of surgery at the 10-year mark, and certainly Dr. Schaefer and colleagues found very similar findings at the 5-year mark of almost 20% of children with Crohn's needing some type of surgery. Similar studies have been found in pediatric patients who have ulcerative colitis in terms of looking at incidence and risk. And so the cumulative rate of surgery, about 20% at 5 years for children with pediatric onset UC, and that patients with more extensive disease had greater risk for the need for colectomy, over 30%, those who had more limited disease. So something for us to think about as we again approach the care of our patients. So what are some of the factors that predict the need for surgery? And this is not an absolute exhaustive list. There are some caveats, but some things that I want to bring up. One, for patients who have Crohn's disease, perianal, stricturing, or fistulizing disease, certainly the more complicated phenotypes of disease. Folks have looked at ASCA positivity, especially with the increased risk for stricturing disease and need for surgery. As Dr. Rosen did a far more comprehensive job, so I'm not going to go through it, there may be some connection with NOD2 mutations, but as he pointed out, part of that may be because of the increased risk for more extensive small bowel disease. And in fact, I know it's in press right now, but Dr. Steve Steiner's group recently looked at sort of the predictive value of having more extensive small bowel disease on radiologic findings and found that there was a 2% risk in those who had no or more limited versus 17% of patients with Crohn's disease who had more extensive small bowel findings radiographically at the time of diagnosis. So certainly that combination of mutations but also small bowel involvement. And very interestingly, and I know that Dr. Adler touched on it, the impact of mood and anxiety disorders certainly can have a predictive factor, although it's a little bit not completely clear what the exact mechanisms are. I can postulate, but again, just something for us to think about. And what about risk factors for patients with UC in terms of the potential for need for colectomy? The presence of extraintestinal manifestations, significantly elevated CRP at the time of diagnosis, and patients, not only those who already have extensive disease, but those who may start off with more limited disease involvement, but have significant extension of their disease that follow up. So what are the indications for surgery? And I'm sure that we can have this discussion later, but the absolute emergent indications are going to be when you have, especially in ulcerative colitis, someone who presents with toxic megacolon, certainly someone who has a perforation and uncontrollable bleeding. Fairly significant, maybe not necessarily emergent, but still urgent indications could include acute severe colitis that has been medically refractory to therapies, the presence of a fixed stricture and subsequent obstruction. The patient who develops abscesses will have to have most likely some sort of intervention. Certainly debilitating symptoms, whether it's significant perianal disease that just cannot come under control medically, and disabling side effects of the medications themselves. And then elective surgery, meaning, again, not emergent or urgent, but may be indicated, including dysplastic changes, which we really don't see so much in pediatrics, but as we diagnose kids younger and younger, and we think of children and their duration of disease, we very well may be seeing more of these children, and growth failure as well in patients with Crohn's disease, especially if there's a fixed area that is contributing to the growth failure. So what are some of the things that we need to start considering when we discuss surgery with our patients and their families? And so I think before we even move with the discussion itself, we as physicians need to ensure that we not just look at the disease and stage it appropriately, but also remember that there are going to be increased complications, especially in a patient where you know that there are going to be certainly emergent or even elective indications for surgery. So make sure that you limit the steroids, make sure you address the nutritional status, address hypoalbuminemia, especially if it is in conjunction with certainly poorly controlled disease. Involve the surgeons in medical decision-making early in the process. And we'll talk about this a little bit more, but I think often when we come in to a family's room and say, okay, we're going to call the surgeons now, and their child is at that point really at that urgent emergent status, you've got families when they are probably not psychologically at their best in regards to making the decisions and coping. And it's even though we think it's a medical decision for the families, there really is a big sort of psychologic and even concerns of quality of life sort of decision-making process ongoing. So you need to introduce them early on if you think this may even be a possibility. And certainly, even though I said you really want to minimize steroids, if someone needs surgery emergently or urgently, you're certainly not going to delay to taper steroids or augment nutritional status, although if you have time, you certainly want to address both. And as we've heard from Dr. Bousfaros and other folks have really addressed this, in terms of the impact of anti-TNF therapy, most likely will not significantly impact the clinical outcomes. So what are the types of surgery? By the way, I'm definitely not a surgeon. I'm not a rheumatologist. I'm definitely not a surgeon. I'm not going to go through all these different types of surgeries, but just wanted to sort of have this list. Again, not exhaustive, but some of the major types of surgery and surgical interventions that we have to think about when we have a patient with either Crohn's disease or ulcerative colitis. But it is important to at least think of these things, and certainly you will be engaging your surgery colleagues to talk in a very proactive manner should this be an issue, to review the types of surgeries. So, when we sit down with families, the first things that we want to really outline to them, what are the goals of surgery? So, again, we need to remind ourselves, I think so often as physicians, we see that surgery is really that last resort, or as a failure. A patient failed a medication. Again, they didn't fail a medication. The medication may not have worked or may have, in that instance, failed them. But it really should not be seen as a failure, but often as a part of the treatment armamentarium. And surgery and medications can combine for a better quality of life. And I think that's one of the things that we really want for our patients and their families. And then reviewing some of the primary goals. Again, you want to prevent future complications. You want to alleviate sort of debilitating type of symptoms that really impact their quality of life. You want to conserve as much bowel as possible. And if having the surgery earlier on rather than later can do that, then that's something that you need to think about in our kids, especially with Crohn's disease, improving growth, improving nutritional status. And again, optimizing the quality of life for the patients that we care for and serve. And so at the same time, I don't know, I'd call them complications, but you want to know what the potential sequelae may be of surgery. And just as we discuss potential both minor and more severe or serious adverse events when we discuss medications with their families, we also need to at least give them a heads up. And certainly they're going to hear a lot of this from the surgeons, but we need to be aware, because after the surgery is done and they do the immediate postoperative care, there still are patients, and these families are going to turn to us. And so for someone who has had ulcerative colitis, colectomy, pouch, you do need to think of potential issues with either pouchitis, and looking at predictive factors. And I'll talk about it a little bit in my next slide, possible things that may increase the risk for pouchitis, as well as the failure of the pouch itself. So they're not really large percentages, but to me, 5 to 15% within a decade are still fairly significant numbers. The issues of postoperative recurrence, and again, for the purposes of this talk, I'll go through a few slides, but that could be a talk in itself, and it has been. Decreased fertility in a good percentage of patients, and we'll talk about that a little bit. And then the psychological implications for those who have an ileostomy. And so when we talk about pouchitis, I've got to, again, have at least one slide that's immune-based, and we need to at least talk about dysbiosis once. So different factors can certainly contribute to the development of pouchitis, whether really it's an issue with more immune dysfunction, dysbiosis, combination of environmental factors. And so, again, when families ask if there are specific predictors, they're not absolute, but I often will say this can happen, and these are some of the things that we have to think of, but certainly we will, be vigilant as we monitor for symptoms that patients may have that may be consistent with that. So what about postoperative recurrence? And I think this is important, and there's several slides, but I'm just going to highlight a few. One is a recent French study that looked at the postoperative sort of recurrence in patients who have Crohn's disease, and just some things to think about. Well, increased risk of second resection, age is less than 14 years. Well, guess what? We're pediatricians. That would be the majority of our patients. Stricturing or fistulizing disease, and certainly more extensive disease, including involvement of the upper GI tract. So when you think about postoperative issues as you talk to your families, remember that patients who have Crohn's disease will have fairly high recurrence rates postoperatively if they're not on a therapy. And thinking of the risk factors, early age of onset, very pediatric, extensive or severe disease, often a lot of the kids we see, colonic involvement, again, we often see that. Smoking, hopefully they're not, but I've learned that, teenagers do on occasion smoke. And when you choose your postoperative prophylaxis, really anti-TNFs have been found to be the most effective. And that surveillance is key, with ileocolonoscopy really being the gold standard. So I think setting the stage up with the families as you discuss all the ramifications of having surgery. So then next, sort of the last few minutes, I'm going to talk about a few issues with fertility, as well as quality of life, and then how we can sort of tie together the discussions with our families. So what is the impact on fertility postoperatively? And again, as pediatricians, we don't really think about it, but we really should. I mean, just because our kids right now aren't family planning, we have to think about what the lifetime sort of impact of the treatments and interventions will be on their life. And so with Crohn's disease, certainly in young women, you can get adhesions, especially if they also have ongoing active disease. And when you look at a lot of the studies of patients with Crohn's disease, yes, surgery can decrease both fertility and fecundity, but they'll also emphasize that control of disease is really the most crucial piece. So it's something that we need to think of. So yes, they've had surgery. You can't necessarily prevent the adhesions, but you can hopefully ameliorate the underlying inflammation. And then with ulcerative colitis, again, you can have decrease in fertility and fecundity, especially when you've had an IPAA due to adhesions and possible secondary fallopian tube obstruction. So these are the discussions that certainly you need to have with the surgeons, especially in young women who are of potential childbearing age. And so just some statistics that, again, look at the impact of conception. And so when you have these strategies, you, again, want to control disease and really work and talk with your surgeons to see if you can be as minimally invasive as possible. So what are the concerns that our adolescents express with IBD? And so there was a recent, actually this was a study a couple decades ago, so half the people in this room were probably not born, but they looked at patient concerns, and the issues of greatest concerns, if you look at it in order, were having an ostomy bag, medication effects, having surgery, and uncertain nature of IBD. And what they found is that disease-related concerns correlated not so much with disease activity, but lower patient-perceived degree of information. So this really emphasizes how much we need to inform our patients. And so a more recent study from Italy looked at how patients, GI docs, and pediatric residents answered the same 22 questions, and it looked at different domains related to quality of life. And so the issues of concern, so first they found, and this is, again, for another talk sometime, that basically the physicians didn't really have the same perceptions of what their patients' concerns were, but the one area that they did all match was the concerns of undergoing surgery. So the take-home message from this is surgery is something that really weighs heavily on the minds of our patients, and at the same time, we as physicians often aren't always correct overall of what our patients' concerns are. And so in terms of ostomy and the impact of quality of life, What this study recently showed is that there are no significant differences in the overall quality of life and PROMIS scores in patients as long as they were in clinical remission, but their social satisfaction was impacted regardless of whether they had active disease or quiescent disease when they had ostomies. But in the other sort of domains, it really, when there was a negative effect, it was more the patients with ostomies who also had active disease. And I'm going to skip through this right now because I see the red light flashing. So my last slide is really on how do we really have the discussions with the families. And I really like how Corey Siegel and colleagues have looked at that concept of shared decision-making where we're proactively involving our patients, especially those who really want to be involved in the decision-making process. And what Dr. Siegel has found is that the majority will want at least some involvement, especially when the consequences are significant. And so as we talk to our families, we need to give them the information and also address their concerns of risk perception, that dread or fear of their perceptions without completely understanding the ramifications, and certainly the unknown when you don't have enough information. So as we work with our families, remembering that we need to address these issues, we need to proactively involve them, and by doing that, improving the patient communications, individualizing when possible, because again, Crohn's disease and ulcerative colitis are not one-size-fits-all diseases, and utilizing things like decision aids, which can also help the families understand the information more. So in summary, optimize medical therapy early, introduce surgery as part of the therapeutic armamentarium. It is not a failure, but rather a part of treatment. You want to address potential postoperative issues so that there are no surprises, but you do the same thing for medications. Be proactive and interactive. Identify the patient's concerns. Understand their perceptions because they may be different from yours. And really engage in shared decision-making. So I want to thank you for your time, and I guess I was the last talk of the session.